on a Saturday morning. My name is Courtney, and I was asked to give a talk today on the intersection of public health and emergency care. So first, a little bit about me. I'm from the United States. I grew up in Washington, so as far west and as far north as you can go without being Canada. I first started working in emergency medicine 9 years ago. The picture down here is a very young me in my first EM job. I went to medical school in Dublin, Ireland, actually. So, and then I came back to the United States, and I did a Master's of Public Health at the University of North Carolina. And then I have come to Nairobi and been working with EMKF since July. So, and that's just my family on the top there, and I grew up riding horses, and I am still an avid fan, so it's a little bit of background about me. Just because I don't think I know anybody but the two in the back, and we're a small enough group, I just want to go around and if people could just say their name really quickly for me and what your kind of background is in emergency medicine.
Hi, I am Dr. Jambi from Region Airport. I'm a medical officer. I just have an interest in emergency medicine.
Hi, I'm Esther. I'm an EMT. Maureen, EMT.
Patricia, I work in ICU.
Talia, I used to work in ICU at Nairobi Hospital. I now just do some school nursing, but I'm interested in emergency.
Gerard, I'm an emergency nurse.
I'm Esther. I am a medical officer. I work in West Pokot County. Planning to join emergency residence.
Great.
That's
There we go. All right, well, it's nice to meet you all. As I said, this is a bit of a smaller group, so some of this we may adjust as we go along, also because we're getting started a little late, so just bear with me. So just to get us warmed up, again, I have a low-tech option. This may or may not work, but I thought I'd give it a try. If everybody has a smartphone and they want to go to this address here, I have a little poll that we're going to test. And again, it's a small group, but your answers should start popping up here. It's just a little warm-up icebreaker exercise.
Can
Can we see the address again?
Oh yeah, sorry. Actually, I can write it here. Check what slash is here. Sorry, it might be a little small. I'll go back to the previous one. Let me know if anybody has any problems. Like I said, I figured I would test this.
Just sit in front.
Did everybody get it? There we go. Some people have gotten it. All right, this one is kind of a test one, and to get everybody, like I said, warmed up in the morning. This is concerning though. All right. So I'm gonna, if you refresh, it should go on to the next one. This is better. Alright. Oh. My personal favorite.
Wow.
And I won't be offended. I fully understand that I've been given a very dry topic for anyone that does not work in public health. We're trying to get you guys awake. Alright. This is the one I'm actually interested to see. The others are mostly for fun, but yeah. I know this probably isn't an area a lot of people have done a ton of work in. So for anyone who just came in, I just had everybody go to this address on their smartphones or laptops or whatever, and if it doesn't work, no worries. This is mostly just for fun and my own personal enjoyment, I guess. But I'll go ahead and go to the next one, and I'll explain this one. So this will basically create a word cloud. So what I want you guys to do is just type in a word or two of like kind of what you guys think of when you think of public health. Like, what does it mean to you? What is it about to you? Because I think I'm going to do this at the beginning and I'm going to do this at the end, because I think a lot of people have a view of public health that is, public health is about curing HIV or stopping you smoking, or very kind of linear paths like that, and it's about a lot more. So just start off with what it means to you now, and we'll compare then. Hopefully it'll have changed a little bit by the end of this. And you can submit more than one time if you have 5 different things you think of, like, put them all in. Right, I think people have a pretty broad view already, which is good. I've done this with other groups, and it changes every time depending on people's backgrounds and what they think of and how interested they are in the topic. But y'all are here on a Saturday morning, so I'd say fairly interested. Yeah, so I'm gonna just, we'll let it go for a second here, but just like take a look at it and see kind of what you see and what you kind of pick out. And like I said, we'll do this at the end as well and see how it might have changed a bit, or it might not at all. And I'll leave it open so people can. Great. All right, so the first thing that I want to start with is what is public health to me? And so we kind of just did that with the word cloud to kind of get a baseline of what you think it is now. So sorry, this is my low-tech option, so we're just going to go past that. And I want to keep this brief, but I just want to give you a short kind of background of where it came from. So public health started way back, as far back as humanity, essentially. So I looked for a date for the theory of miasma, and essentially it's just been around forever. So think of it of antiquity. So it started. The theory of miasma, they had a knowledge that polluted water and waste spread communicable diseases, and this is way back in Babylonian, Egyptian, Roman, all of those kind of civilizations. They knew this already. Religions had regulation of diet and indulgent behaviors, so alcohol, excess, sexual relations, etc., and they knew it affected your health, but maybe they didn't know the mechanism of how and why, but they saw the result. Way back in 1000 BC, the Chinese started doing smallpox inoculations. So they would inhale the dried crust from infected smallpox lesions, which sounds very pleasant. Alternatively, they would give children scratches on their arms, and then they would inoculate that scratch with pus from a smallpox lesion. So a do-it-yourself vaccination, essentially. In 1485, the first Department of Public Health was created in Venice. It was called the Venetian Magistrate for Health. So end of the 18th century, we started to see the beginning of modern public health. So 1796, Edward Jenner invents the official smallpox vaccine, so people didn't have to inhale scabs anymore. And vaccination started becoming widespread across different parts of Europe. In 1848, the Public Health Act is passed in England, and this was primarily to address sanitation and overcrowding, which again they knew bred disease, but maybe they didn't know the mechanism of how and why. Which brings us to the other Jon Snow. 1854, Dr. Snow believed in germ theory over the miasma theory and identified a contaminated water pump, which was the Broad Street pump. A lot of us have probably heard of this. And it was the source of a major cholera outbreak in London. So this was the first time the mechanisms behind these sort of diseases and outbreaks started being investigated. So Dr. Snow is considered to have founded the field of epidemiology, and this is what we mark as sort of the beginning of public health as we think of it and we know of it today. And then sort of the end of the 1880s, the first Infectious Disease Notification Act was in England, so this was your mandated reporting and surveillance authority. And then from there, the 20th century, we started forming kind of the big organizations that we think of today, and CDC, or kind of modern public health. So what I want to get out of this is the solution can be simple sometimes. Public health doesn't have to be complicated. They solve the outbreak by removing the pump handle. So simple solutions do work, and you don't need to have a big fancy degree or credentials or all these kind of things to make a difference in public health. So nowadays, we think of public health as many players. It isn't just about an agency or a clinician and a patient. It brings in all of these sorts of groups, and when we're working in public health, we have to think about all of these stakeholders and what all of these people are affecting. This is a different word cloud. There's many descriptions for public health now, from your kind of traditional drinking water to social policy, indicators training, HIPAA, which is, for those who don't know, it's a Data Protection and Privacy Act in the States, aging. It's very vast now. But it has one overall function. Public health promotes and protects the health of the people and the communities where they live, work, and play. And I think where they live, work, and play is very key. Who is the public? So this is just to illustrate that the public can be many things. It can be any sort of group. And I think a lot of people think of public health as people that work towards the health of the whole country or a big section of it, but public health can be about a small group of individuals. This can be your patients. This can be, the people you see on a daily basis. It doesn't have to be, you don't have to think about it as like so large. It can be much more personal to you. So I'll go through the PowerPoint part of this fairly quickly so that we can get to the active part and keep you guys awake. But if we think of public health in our traditional roles, we think of surveillance. So hold up Houston, we have a problem, we see something happening, let's look into this. We think of identifying the risk. Why is this happening? Finding that mechanism. So, Dr. Snow identified there's a cholera outbreak, and then he identified the risk, which was the water. Next thing traditionally we would do is develop an intervention. Eureka, we found the cure, you remove the pump handle. And then the last thing is implementation. So time for mass production. But that's the sort of traditional roles. When we think about how public health has changed a little bit, we think about all of these, where we bring in a lot more policy, we bring in a lot more prevention, partnerships, and these can be thought of as kind of three main areas. So you can think of assessment, policy, and assurance, and all of these their foundation is research. We need to know what we're doing works and that there's evidence behind it. We can't just be spending resources because it sounds like a good idea in our head. So, yeah. And there's obviously quite a bit of overlap between these two, but it is a much less linear process than what public health used to be. But the long and the short of it is still, we prevent, we promote, and we protect. So, just a humor break, as it says. I think that's quite pertinent to many of us. So now we know what it is. Why do we care about it? And why do we care about it as clinicians and as people interested in emergency medicine? Because isn't our job just to treat the patient? So I want you to kind of, probably not groups of 3, but just groups of wherever you kind of are, and just take a few minutes and discuss why you think public health is important for people who practice clinical medicine. Like, why should we care about the research, the advocacy, the policy, all that side of it? And then we'll just, once you have a second, we'll bring it back and have a little discussion. So just throw out a few of the things that you talked about why public health is important to think about when all you want to do is practice clinical medicine.
Okay, it's important because we found that if you treat the major issue, the patient, let's say in the emergency department, and you've not really taken care of the problem, which is in the community, this patient is going to be back. And if it's a major issue like cholera, as much as it is treated, if the major point of infection and all that is not taken care of, you still get more patients. So,
Next. I'm trying to look pointedly, but there's a video.
Okay, maybe we are thinking about awareness, as in we teach the general public what leads to what, or what can cause what. I mean, I don't know.
So like public education, so that
Yes.
they know what they can do to
Exactly.
prevent it.
Yeah.
hauna point.
Circling back to this side of the room here, so.
Well, we were thinking that the clinician needs to know what's happening out in the public field, so if there's an outbreak of cholera or something, you can isolate. Maybe or if there's an Ebola outbreak or something. You don't want that to
I think that's a really good point, that like, as a clinician, if you're not thinking about what's happening outside of what goes on in your office or your interaction or your ambulance ride or whatever it is, you're really starting behind the ball here. You know, like how do you even know what to do if you don't know what's going on? You guys ready?
Clinicians need to know the policies that are being implemented and the ones that are not implemented.
And the ones that are what, sorry?
Sorry?
The ones that have been implemented and the ones that are...
Implemented.
what emergency?
I'm just knocking everything down here. Yeah, I think those are all important points, and I think those are all, those cover a lot of the broad categories. The one thing I would add as well is I think that clinicians don't think about their role in public health as much. So when you're telling a patient they need to lose weight or stop smoking, or like, that's public health. So if you think about awareness of what's going on in the greater public health world, so we talked about policy and outbreaks and things like that, you can take this information and distill it down to a moment that you interact with your patient. And I think when you have that mindset, it goes back to treatment at the source rather than just the problem. And I think that, there needs to be a greater connection between what's happening in your interaction with that patient and what's happening in the greater world. Even if you decide you don't want to be, somebody who sits in policy meetings and advocates that way, like, you still have a role in public health. So this is what the WHO thinks of when they think of emergency care. So the reason I'm showing you this is because what I want you to get out of it is, your interaction is here, maybe here, and here, but there's so much more happening. And when we think of the intersection of public health and emergency care, this is what we think of. We think about the entire system, rather than just wherever it is your interaction falls in this, because if you're, the hospital provider, all of this has to happen to get that patient to you. And if none of this is happening, you can't save them. Like, you can't do anything if all of these parts don't work together. So the key here, emergency care is not just about the provider treating the patient. Whatever role you play in that interaction, whether you're an EMT or a physician or a rehab provider, any of it, it's not just about that interaction with the patient. So that just shows it again. And then, in the words of Dr. Benjamin Moshier himself, one trained doctor is not enough to resuscitate a patient. It requires building an entire emergency care system. I'll wait a minute so Emily can get her photo. I see. And then when we think about this is really the role of public health and emergency care. It's about building that system. And even if you don't want to play that active of a role in building it, like I said, policy advocacy isn't your thing, you still need to be aware that it is a whole system and how that system is working, because like we said there, if you're tunnel vision to that kind of one moment in time, you're not doing your patient any favors. Hold on here. So, another little exercise, because I'm not going to sit up here and speak for 2 hours, I'm going to make you do part of the work. So, if we think back to that figure I showed you, and I'm not going to put it back up because then you could cheat. I want you to think about a road traffic accident happening somewhere in, we'll say Nairobi because we're here, and you have critical victims, so they need to go to the emergency room. Think about the process of getting those victims, as it stands now, not as how you want it to be, as it is now. How does that patient get from the roadside to, the ICU or the emergency department, and who plays the roles in between? You don't know to shuffle?
Actually, take you to
Remember, they are all in
Bystanders. the coming and the
If you need some caffeine to think through.
Bystander, okay. And what do they do? And is this a good thing?
and they first steal.
They rob you first.
Okay. Do they just pull them out, leave them on the side of the road?
We take photos, we take videos of
Of Instagram.
You go live.
Alright, we got some good things going here. Probably not helpful to the patient, but
sometimes using the stolen phones.
they get the stolen phones. Alright, so how does this happen to the patient maybe getting a medical care? Like how does that work? Again, this is how it now, not how it should be. Does it work at all?
The police. The police
The
are
bystander?
Yeah.
Stop random cars.
Asking for, asking for them to help.
Think comes before calling the police.
Alright, now we have the police.
before the ambulance.
Take forever.
2 hours.
They will come after us. Go to the hospital.
I am right.
You just put a long line.
Alright. What role do the police play then? Sorry, I should turn this.
An ambulance is called.
But, okay. So we finally got to
When the
ambulance.
police comes in, most of the times ambulance comes into. Yeah.
Okay.
I
It
think
takes
I
big
most
steps
of the
from the job
time.
there.
The police first.
Before that, the police will declare some of the victims dead.
Yeah.
Or they can choose to actually just use their car and take you to hospital.
Oh yeah.
They don't call the
It
ambulance.
could
They
be
put
the
them in the-
ambulance or the police.
The police vehicle.
999 vehicle.
Yeah.
Inaitwa Maria.
Yo.
Mariam.
Mariamu. Right there, Mariamu.
You're fixed in the police car. Take them.
Alright.
Just write police car.
So now-
we are using local slang when you say Mariamu and 99.
Alright, so we have maybe an ambulance. Now what?
They're taken to the closest
Hospital.
not facility. Facility.
Yeah.
Let's be specific. Facility. Because some of those we need clinics.
Health center.
Health center you even tried.
Yeah, true. Dispensary.
So to survive.
Alright.
Yeah, closest. I like what he said. Closest, most irrelevant facility.
It's either that or they go straight to Kenyatta.
Yeah.
All right, we've arrived at
Proximity.
a facility.
Yeah.
What happens now?
So
Let's
you're
assume
either,
it's not Kenyatta.
you're either given care or denied care. Yeah.
Deposit.
They should.
So denied care.
If they don't have the capacity, they move to the next.
Sometimes the ambulance, sometimes the facility refuses to
receive.
take the patient. So,
Okay, so
yeah, true.
and okay, now they've been denied care. What happens now?
Move to the
Move to the
next.
next
To the
one.
next one.
Go facility shopping.
Yeah.
Facility.
18 hours in an ambulance. You see how
You're in a taxi. I'll add that. So this has all happened, and we're still not any closer to treating the patient, eh? So we'll assume eventually they either die or get care. Okay, so now that we've mapped out what it sort of looks like now, I'm sure most of you already knew this. The reason I wanted to do this is I wanted to start getting you guys thinking like a public health worker when we think about the whole system. So, this is the next activity. When we look at everything we just described, what's missing? How,
Help.
Everything.
yeah, what's going wrong here? What needs to be added?
a lot of things.
I can't. Okay. I'll list some things and then I'll edit the beautiful drawing. But I think more than just thinking everything, I think I want you, what I want you guys to do is I want you guys to think critically, like I said, think like a public health worker, like somebody who wants to fix the system. We can't just say everything's wrong. We have to think about what parts can be affected, how can we change them? So help should go by piece if you have a personal preference or a personal, attachment to a certain part of this. So I can give you a few minutes to discuss it, or we can just start throwing out. It's up to you guys. Okay.
So, I think awareness is missing from the point when the bystander comes in. If they were aware of existing emergency system, they wouldn't even be trying to do all these things, and they would be trying to save life first, not stealing and taking photos.
So we're saying awareness and let's say education.
Education, yeah.
Okay, so that's the bystander. What do you want the bystander to do? What are you teaching them this awareness and education?
To initiate emergency response.
Okay. This is gonna get a little confusing, but actually, we'll do this. So, we'll have our little victim here. So, we have a bystander. So you want them to call the 999 number.
Yeah.
I almost put 911, sorry.
999.
And to do this, we need education. Okay? They've called, now what?
999 is the
Who's responding though? Like who is 999? Who do you want to come? Alright. So bystander sees, they know not to pull the person out, not to steal things, not to take photos, but to call 999.
Mhm.
Theoretically, we get that to go and get police and ambulance. What happens once they're on scene? What should happen? Who's in charge? Sarah say, okay. And what do the EMTs and the paramedics do? I know, it seems obvious, but I'm making you list it out for a reason. What? Do they just throw in the back and go?
No.
Or do they stabilize them at the scene first? Do they?
triage, stabilize,
So
treat, transport, and inform the receiving facility.
and before that, safety.
Scene safety, I get that. We'll say that's a police job too. Okay, so patients on their way. Where do they go? Closest facility? What facility?
Trauma center.
Relevant. What's the relevant facility?
The closest
Emily's not allowed to answer.
Hmm.
So I'll just put what facility? And if you don't know, you should probably be following EMPF on Twitter and Facebook and all those things. Clinic,
Which
hospital,
facilities do you take your patients?
The county hospital,
the county hospital.
the nearest county referral hospital.
Does it have to be a county referral hospital?
No, you take the facility where the patient needs can be handled.
Yes.
Closest, most relevant, I think,
No.
because it depends on the condition of the patient.
Okay,
Yeah, closest, most relevant.
so I have a question for you. I'm not saying you're wrong. So what happens if those patients' needs change? So if you take them to a facility and they seem fine, and all of a sudden they become not fine. Because we're thinking about somebody who is in, this isn't just like a fender bender, like
Yeah.
this is serious accident.
Trauma.
So,
But I think you'll have made the call first,
Yeah.
but because during that call, age, name, sex, condition of the patient, they give all those things. So they'll kind of have
yeah,
an image of,
no, I'm not saying you're wrong, I'm just, how would you then, if that patient, how would you deal with that situation? Because these are the questions people are gonna ask you when you're talking about building the system, and you gotta have an answer to them. So I'm forcing you guys to do this on a Saturday morning.
so maybe they'll stabilize the patient further, more than what I did,
Mhm.
because of my,
So, I'm just, make sure I'm
and then
understanding.
we'll refer.
Yeah, so what you're saying is take them to, depending on what their kind of needs are,
Yeah,
when you give your report, you triage them, take them to the nearest facility that can stabilize them,
Yes, exactly.
and then transfer them from there.
Yeah.
Okay.
Sometimes the accident is in the peripheries,
Mhm.
where maybe the nearest facility is maybe the nearest level 4 or level 5 hospital. So they go to the level 4, they get whatever attention, maybe, and then now they can be referred to either Kenyatta or level 5 with oxygen, with all that stabilization with an EMT or a nurse inside the ambulance.
Okay. Yeah, because I think what you're saying is kind of like golden hour treatment, that first hour that's very important. So if we're saying the closest relevant facility, and again, Emily is not allowed to answer this, what does that facility need at the baseline? What do you think minimum they need for any kind of a trauma victim?
Operational theater.
I see.
Love imaging.
So OR, farm, imaging. Anything else? Is this, do we think this is enough? What about staffing? Who needs to be here? Just a warm body? Entire team? So doctor, nurse, surgeon? Anything else? Or are these the main things that we need to think about when we think about a relevant facility?
The doctors.
Yeah. So we have doctor, nurse, surgeon. Anybody else? Those three gonna be it? Huh? Radiologist, yeah. Yeah. We'll assume lab have staff and pharmacy has staff. Like. Okay. So we've gotten the patient from the scene to a relevant facility that can treat them. Is that it? That's the whole, is that it?
No.
No? What next? What happens now they're stabilized? So if they go home, okay, they might do this. Can't spell. There we go. So we might have home. What are our other options? And I know, like I said, I know you guys know all this. I just want the points written out so that we can think about them. Because each of these is a point that has an important role in the system. And when we think about improving the system, we can think about, okay, public awareness, education, calling 911. So we think about how do we improve this. But you can't, like I said, you can't have tunnel vision. So you need to think about what am I doing here? How is this going to affect everything else in the system? So drawing it out visually just gives us this kind of a reference. So patient stabilized, they might go home. Now what? What else? This hospital? Different hospital? Could they be admitted here?
Yes.
Admitted with the ward.
Your guy, I'll put that. So we'll do this. Okay, so probably at this stage, most of us, unless you work in the ICU, we're done seeing the patient. The EMT, well, again, EMTs might be doing the transferring here, but so does it end when the patient gets admitted or goes home or is transferred? Like once they're, or say they're discharged after they've been admitted for a month or whatever. Is that it? Is that the end of the system, or is there something else we need to think about at the end? Follow up? What kind of follow-up? Pardon? Rehab, that's the one I was going for. So we've kind of followed the patient's path here, and I think one thing that I think is important, and it affects every part of this, but is a part of rehab, and it's a part that's overlooked, and again, this is my own personal hobby horse because I work in this area as well. So when you think about rehab, you need to think about the mental as well as the physical. So this isn't just about getting them to walk again. You know, there's a lot of consequences to all of this, and I think that mental health is very much overlooked in emergency care. Like we deal with them when they get here to the department or when police are called or whatever, but like, again, that's kind of treating the symptom, not the cause. So, you know, if you're thinking about somebody that's gone through all of this and now all of a sudden they're disabled, you know, and they start drinking or using drugs, etc., then they start going into this whole other cycle of issues that's also going to show up in your emergency department. So if you think about we're building this ideal system. So when you think about support for those kind of things in rehab, you can head it off before those start. So physical, because a lot of these people are going to have long-term, like I said, consequences. So, these are the sort of questions when you're thinking about how a system does run versus how they should run. The three broad categories you can kind of think of is how do they get to you? So whatever part, whether you're first on scene or you're in the rehab hospital, what's the process of them getting to you? You can apply this to whatever your job is in the system. Even if you work in policy and advocacy and you are not anything to do clinical, that patient's information gets to your desk somehow. What happens once they're there, and where they go next, and what happens. So if you just do your bit here and don't think about this part either, you know, you're gonna send patients home who can't afford their medication, they can't afford food, they don't have housing, all these sorts of things. They're not gonna get better if you don't think about, you know, what you're asking them to do and can they do it? You know, do they know how? Do they have the education to do it? So this is my own sort of list of following the patient's path. So we discussed this. We have recognition of an emergency and system activation. And this isn't just road traffic accidents. This is if you're at home and your mother has a heart attack, whatever, like bystander care. What does the bystander do? Okay, they've called your 999 number. What do they do? How do we teach them what to do? When does that training start? Does it start in schools? Does it start in universities? Does it start in community events? Like, where does that come from? You have your pre-hospital response, so your dispatch, your care at the scene, and your transport. And there's a lot more that obviously goes into all of these. You're stabilized in your emergency department or emergency care area, whatever that's going to be. Your options, admission, discharge, or transfer, and then we have follow-up and rehabilitation. So when you think about it, when you think about fixing a system, just be logical. Follow the path and identify the steps and the moving parts at each part. Don't just be like, even if you're picking an outcome and say you want to decrease the rate of X, like you still have to think start at the beginning and think through step by step, no matter what part you are in this step. So another point I wanted to make is the sort of requirements for building a system. We talked about these a little bit. We talked about education and advocacy. The public, but also doctors, nurses, clinical officers, ENTs. This isn't just about like a PSA on the television. And you also have to educate. When you're doing advocacy work and you're doing policy work and you're working with governments, you have to educate them too. You can't just go to them and say, I am running a hospital or a doctor or nurse or whatever, and this is what we need to do to fix this for patients. Okay, show me a reason why. You need to back it up with education, statistics, data. Like, show them why. Because if you just go to them and be like, I have a great idea, you're gonna wonder why you're not getting anywhere. Which kind of, again, the policies we do, they need to be evidence-based. Like, they need to come, and if there's not evidence, maybe you should be the one to create it. Like, you need to, you need to think about where is this coming from. I think another key point too when you're thinking about emergency care systems is not just where is it coming from, but will it work here? That's great that it works in Germany, but like, none of us currently live in Germany. Like, you need to think about, can you take something that's successful somewhere else, and can you alter it a little bit and make it suitable for the culture, the resources, the amount of financial resources you have at hand, the workforce, all of those kind of things. Third requirement, funding. This is everybody's worst nightmare. You have to think about the practicalities of this. Somebody has to pay for it. So if you're trying to fix the system with some big, expansive, fancy program, unless you are best friends with Bill Gates and he just happens to give you a great inheritance, like, you have to think about, like, how can we do it as cheap as possible? Because public health doesn't have a lot of money. So, going back to that pump handle, like, yeah, we all want the biggest, fanciest, pre-hospital system or ambulances with all the equipment, all that kind of thing. But like, holding out for that and doing nothing in the meantime doesn't get you very far. So if you can look at simple, effective options like removing the pump handle, didn't cost them anything. Those are great starts, and like, yeah, we all want that big fancy system in the end, but you can do things in the meantime. And the fourth thing you have to do is you have to take all this and you have to implement it, which many hours, lots of manpower, lots of blood, sweat, and tears, So now that we've seen what we have, what's missing, we've talked about these sort of kind of your big requirements for building the system. We're going to do one last activity. This one's going to be a little harder, and I will have you kind of break into your groups again. It doesn't have to be perfect, but I want you to think like a public health worker. So think about one of these missing parts, again, whatever one you want to choose, if you have a personal attachment, etc. And I want you to think about, how does this issue affect your patients in both the short and the long term? How would you approach this problem in Kenya? So think about the resources you have. What could you do? Who should be responsible for it? So like, you want to bring something in, is that police, is that EMT, like who's responsible for it? Is somebody playing that role already, and can that role be expanded? Should it be assigned differently? Like, this is just, again, remember the pump handle, it can be simple. I'm not having to write a dissertation on this. I just want you guys to kind of take, you're the ones who are going to fix the system. So you're the ones that need to come up with how that's going to happen. Like, it can't just be, it has to be everybody doing it. And so, again, it can be, just throw some ideas out there. The other thing that you want to think about is, who are the stakeholders? Who's going to agree with you? Who's going to disagree with you? What are those obstacles going to be in your path? Bonus, is it sustainable? So yeah, I mean, like I said, I know this is kind of a big ask, but just, it doesn't have to be big, it can be something super small, but this is kind of the process that we think of when we think of how we're going to approach a policy body or funding body or any sort of, and like bring people on board for what we want to do. We have to have, why is it an issue? How specifically, what's happening to patients, what's happening to staff? You know, you have to have your plan. And then you need to know, you need to be aware of who's going to be all for it, who's going to definitely not be. So, yeah, I'll leave this up and I'll give you guys a few minutes and then we'll just go around and kind of briefly share. Like I said, this is mostly an exercise to get you thinking about these kind of things because you're the ones that need to be involved in them. I think you guys were talking about, sorry, you were last time, you're first this time. I think you guys were talking about like primary school education. So we'll start with you, and then I think a few other groups had the same kind of idea, so we'll let them add on to it, so.
Okay, so, we were talking about introducing first aid and emergency care to primary school, where you talk to the kids about what to do in case of an accident or maybe an emergency at home, educate them on what to do, where to go, and also how to give way to ambulances, and
Yeah, because we talked about, with this group, so we talked about, when we're thinking about education in school, it doesn't just have to be your kind of first responder education. You can kind of think about what other parts in this system can you pull in. So you can talk about knowing what facility to go to, that if you go to the chemist or the dispensary, they're not going to do anything for you if you have a heart attack. Talking about, giving way to ambulances and all of this sorts of things. Like, I mean, not to sound like a broken record, because I think this is like the catchphrase of all public health, but education, education, education. Like, you can affect this school group and you can talk to them about multiple different points here. I mean, you can talk to them about rehab, mental health, like all those sorts of things, and then they go home and they talk to their family. They talk to their aunts, their uncles, their, parents. Like, this is a mobile force you're sending out. So there's a reason everybody targets primary school for education. So, so we talked about what to do, where to go, how to give way. Was there anything else that you wanted to add to this before we go on to the other education groups?
Importance of timely care.
Yeah, that's a good one. So we have I know in the States we have a lot of kind of acronyms, so things like strokes, we have acronyms for people to check facial droop, speech, things like that, and they're fast in face and super easy things to remember, and all of them, the point of all of them is do it as soon as you think there's a problem, do it quickly, don't wait. And giving people, I think, tools as well, easy things to remember, that if they think, oh, maybe this is a heart attack, or this is a stroke, or this is, whatever, this is a thing I can remember, I can check, and then I can take them in. So I think the group behind was education as well. Did you have anything you wanted to add to this, or?
Continue the education refresher in secondary and university, teaching the teachers, educating the teachers.
Teaching the teachers?
Yes.
Yeah. I think we talked about this, this is running out, but whatever. I think we talked about this with a couple people. When we're talking about sustainability, this is probably the biggest single thing in public health is, okay, you went to all this trouble to make something happen. You want it to keep happening, you don't want to do it again. So, and you think about teaching the teachers, that's a huge resource and financial save. If you you can teach the teachers once every, whatever the turnover is, 5, 10 years, whatever. And they can then do the yearly or the refreshers or whatever, like I said, there is some specialized training that, it would take a little more. I mean, you could certify, certainly you can teach teachers to teach CPR and all those kind of things. It's just gonna be a little more intensive process for you financially and resource-wise to get them to that stage versus, recovery position, opening airways, calling 999. I mean, that can be done in a 30-minute presentation. But these are but thinking about sustainability, I think, is key in anything that you want to do. So we'll skip, I think you guys had education more for police, so we'll skip to the other school children. Did you have anything that you think should be added to this sort of idea? You can say no, that's fine. So I think you guys also had education, but slightly different. Do you want to talk just a little bit about what you guys talked about?
Yeah, we're thinking about educating the general public, the importance, because if we, the first group, I like your idea of training the school children so that they'll grow up knowing it. But if we start it now, we have a gap. Then we have a population that know nothing about basic first aid. So maybe we can, as we teach the school children, we can also teach the public the importance of having ambulance numbers, knowing the proximity of the police stations to the scene of the accident, and also going to the police training colleges. We train the police to be knowledgeable in life-saving skills, like even the public, you can teach them how to stop a bleed. You call the ambulance, but stop a bleed before the ambulance comes. Instead of looking at a patient bleed their life out. The police also need to be proactive. Here in Kenya, you call the police, they come to call the ambulance when they arrive at the scene. Instead of calling the ambulance as they leave the station, hey, let's meet at James Gishoro, we have an accident there. They come to the scene to call the ambulance from there. It's all wrong. And maybe just an afterthought. We can also teach about infection prevention and control, because that one does not involve RTAs and the sort.
So is you talking for police for that or public?
All of them.
All of them.
All of them. Yeah. Don't use the same gloves on bleeding patients across.
Yeah.
Oh, these days they put on, but they don't change. I've noted.
They put on which public?
No, police.
Oh.
They do.
It's the same for everyone.
But they don't change.
Just change.
I think the only other thing, just in the interest of time, saying we have about 10 minutes left. Oh, did you?
This is just something.
Yeah.
Maybe we can have a one dispatch system for both police and ambulance, so that when the dispatch system is called, it can dispatch both the police and the ambulance. It will be easier.
Yeah, so we think about one system. And yeah, I think that's, you need the eagle eyes that aren't involved in this to keep awareness of the entire situation. And I think that's something we do a lot in kind of disaster management and mass casualties, but it matters for all of this. I think the other thing that kind of is less to do with education that this group mentioned that I thought was really good and I wanted them to share was your Boda EMTs. About having for the getting people to the scene sooner.
Oh, okay.
I don't know whose idea that was.
Okay, we're saying, because of the traffic, maybe we can have motorbikes that are led by EMTs or paramedics, so that they can get to the scene before the ambulance arrives. So they can stabilize the patient. When the ambulance arrives, the patient will be ready to go.
Because of traffic issues and the jam and
And I think that's a good example of not trying to take some system, and I think this is universal for kind of whether you're doing business or medicine or whatever, not taking somebody else's system and just dropping it into your area that you're working and expecting it to work. I think that's a good example of this is what the current situation is in Nairobi and in these areas. Let's think of something that would work for us. You know, and I think I thought that was a great idea, and that's, I told Emily, it's part of why I did this exercise is because, you know, you guys can come up with ideas to fix the system too, and it saves a lot of work for the people that are, you know, in public health as a career, you know, which I think to some extent you all are in public health as a career, but, you know, maybe you prefer to spend more time with patients, and that's fine. But like I said, it saves a lot of work for the rest of us. So, like I said, we have about 10 minutes left, so I'm just going to finish off, pull it all together a little bit. So the bigger picture, the WHO lists emergency care as a critical component of universal health coverage, and I think this is key. 1/2 of deaths and 1/3 of disability in low and middle income countries is a direct result of ineffective emergency care systems. So that is a huge number, and obviously we've kind of identified there's a lot of kind of issues in that system, but even simple things can drop this significantly. And I don't think a lot of people realize, like I was telling someone the other day, I think in public health in the past you have sort of hot topic items. So it started with HIV and like this kind of the global public health thing. So in a lot of low and middle countries you're talking about HIV, then you went on to maternal child health, and now it's starting to turn to emergency care, which is great for all of us because they've started to identify, okay, that's great, we get people to live past infancy, but when they still die when they're 19, it's not helping them very much. You know, you're not reaching that goal yet. Yeah, and like I said, public health, it isn't just about anti-smoking campaigns, it's about a lot more than that. So what can I do? 3 takeaways, you know, three different ways to say the same thing. We need to encourage systems thinking for clinicians. I think that's part of why I was asked to talk about this morning is just to get people thinking about more. Making our patients healthy requires thinking about the whole picture. You know, just thinking about writing them a prescription or dropping them at the hospital doors, that's not enough. And I think really key is to think horizontally, not vertically. So even if you're thinking about one particular issue that you want to fix, you know, whether it be a 999 or, you know, or we'll say you feel like you need to have this piece of equipment that's not there and that could save a lot of patients' lives. You still need to think about horizontally the whole system. You know, if you just think about vertically, that's great, you have that piece of equipment, but who's being trained on it, who's paying for it, who's making sure it still has the supplies, you know, all of those sorts of things, you know. And then, so, I'm not sounding like a motivational poster, but if not you, then who? You know, who's gonna do it? You're the people that work. You're the people that work on the front lines, you know the issues. If you don't talk about them and you don't think about them and you don't bring them, those people sitting in the offices and the boardrooms that give you the funding or make the legislation, they're not gonna know it's an issue, you know? So, alternatively, do it for selfish reasons. You might be the patient someday.
Yes.
And finally, this is my favorite, public health is about finding a way to fix the problem so we don't have to put a Band-Aid on the results. And apologies if you call it plasters, I'm American, we call it Band-Aids. So, yeah, and that's it. And then I think we still have time to go back and do the word cloud again, and we'll just take a look and see, compare the two.
Any questions?
Yeah, any questions?
Melewa na mmelewa. Melewa na mmelewa.
Melewa? Yeah, it's Saturday morning.
got a question.
Sorry.
I came in late, I didn't get to know your name.
Oh, I'm Courtney, sorry. I'm Courtney.
Oh, that's your name?
Yeah.
Ah,
It,
okay.
it registers it to like the presenter's name.
Oh. And I'm Benedict.
Nice to meet you.
Manifesting, Martin.
Yeah, I'll just say it again for anybody who came in late. I won't go through the whole thing again, but so obviously I'm American. I've been working with EMKF since July, and my background is I started working in the emergency department almost a decade ago, and I actually started working before I went to med school. I went to med school in Ireland, and then I went back to the States. I went back to the States and did a Master's of Public Health at the University of North Carolina. So I took an emergency medicine addiction that started very early on in life, knew I wanted to do medicine, and then circled back around to public health and started combining the two, and then ended up here. So I appreciate the Band-Aids, whoever put that.